illustrated by the PURE data, which was published by Salim Yusuf about a year and a bit ago. And this indicates that the use of preventive medications post-cardiovascular disease is disappointingly low worldwide. In high-income countries, you have about a 50% chance of being on aspirin, statin, and blood pressure-lowering therapy after your heart attack. And in fact, if you look at United States data, that was well illustrated by the MI-free trial that was presented here last year and caused quite considerable attention. And in those data, the adherence rates in a very similar post-myocardial infarction population was only around 40%. So these are pretty prevalent data. And in low-income countries, you're pretty likely after your myocardial infarction to be on nothing at all by way of preventive medication. In 2002, the WHO called for trials of a polypill cardiovascular disease prevention strategy, a fixed-dose combination strategy in CVD prevention. And in 2009, the European Commission echoed that call and emphasized affordability and access in lower middle-income countries. And consequently, the UMPIRE trial was designed in response to these calls. And what we've done is to conduct a probe-designed trial to test the hypothesis that a fixed-dose combination-based strategy, a polypill, for delivery of preventive medications, aspirin, statin, and 2 blood pressure-lowering agents, compared with usual care, might improve adherence to indicated therapy, and in parallel, systolic blood pressure and LDL cholesterol at the end of the study. Importantly, this being conducted in people with or at high risk of cardiovascular disease. Prospective randomized open blinded endpoint design. Patients with established disease or estimated 15% 5-year risk, aiming to include 2,000 in India and Europe, and randomizing the participants to a treatment strategy based on a fixed-dose combination or to continue with usual care. You can see the inclusion criteria at the top. The exclusions comprised contraindications to or known intolerance of any of the combination components. And you can see the schema for follow-up. The final follow-up was scheduled to be 12 months after the last randomization. So the range of follow-up could be between 12 and 24 months. The methods, importantly, we assessed adherence by self-reported use of antiplatelet statin and more than 2 blood pressure-lowering agents, and being adherent was defined as taking that package for more than at least 4 days in the preceding week prior to the visit. The other point to draw your attention to is that there were 28 trial sites in India and 3 in Europe, and the recruitment phase took place over the course of a year, 2010 to 2011. There were 2 versions of the fixed-dose combination, 2 versions of the polypill, one containing aspirin, simvastatin, lisinopril, and atenolol, the other with hydrochlorothiazide substituted for the atenolol. Physicians could supplement or change medications as they wished. We made no stipulations about usual care. Participants in the fixed-dose combination group were dispensed the chosen combination free of charge from their trial centers, and I suspect this might generate some discussion or controversy. Participants in the usual care group acquired their medications subject to local payments or exemptions. That's the consort diagram, how the trial flowed. The majority of patients, only 134 of the screenees were ineligible, so we randomized 2,004 with equal numbers in India and Europe. Minimum follow-up was 12 months. The median follow-up was 15 months. So there were actually relatively few visits, relatively few people being followed at months 24. You can see the small numbers, 34 and 36 on the left and right. The other thing to draw your attention to at the bottom there is that data capture at the end of the study was very good. High level of accumulated data in all the categories of the primary endpoints. These are the baseline characteristics bringing you to the results. And what you see here is that the majority of patients were recruited on the basis of established cardiovascular disease, 88%. You see also just above that the systolic and LDL cholesterol values. And then drawing your attention to the baseline drug treatment, what I want you to notice is that an extraordinarily high proportion of participants were actually reporting taking the combination medications indicated at baseline. About 61.5% were taking the combined package of statin, antiplatelet, and 2 antihypertensive drugs. And that's a high level. Reported use of both aspirin and statin was also particularly high, 91 and 88% for each of those. Showing you the primary endpoints, the effects on primary outcomes at the end of the study. At the end of the study, 86% of those in the fixed-dose combination group were taking the indicated medications, compared with 65% in the usual care group, a relative increase in adherence of 33%. And this was paralleled by a 2.6 millimeter reduction in systolic blood pressure and a 0.11 millimole reduction in LDL cholesterol, all highly significant. This shows the data for adherence by sequential visit, baseline through to month 24. And you see at month 24 there are very few attendees, so the data at this point are not robust, as also illustrated by the wide confidence intervals. So those points at the end carry very little weight. You see at baseline the high reported level of baseline medication. In both usual care and fixed-dose combination groups, adherence initially increased dramatically so to 97% in the fixed-dose combination group and remained higher than baseline by 18 months. By 18 months, there was a 22% absolute advantage in the fixed-dose combination group. So adherence was consistently maintained advantageously throughout the course of the study. Essentially, I've shown you these data already, the beneficial reduction in systolic blood pressure that paralleled that improvement in adherence, and the beneficial reduction in LDL cholesterol. Again, small numbers at month 24. This is the adherence effect by pre-specified subgroups, illustrating subgroups of cardiovascular risk, subgroups of reported baseline medication, and subgroups by continent, India and Europe. And 2 points to draw your attention to here. One is that the strongest effect modifier was whether or not individuals reported taking indicated medications at baseline, and in those not doing so, there was a more than threefold increase in the adherence effect. So you were much more likely to be more adherent in the context of using the fixed-dose combination if you were not doing so at the baseline. And the other thing to emphasize is that the effect of the strategy was very similar in both India and Europe. The secondary outcomes, there was little difference in any of the other lipid fractions. There was some improvement in adherence at 12 months, which was a secondary outcome mentioned, and in diastolic blood pressure. There was a small increase in creatinine. There was an improvement in quality of life, measured by the EQ5D questionnaire. Cardiovascular event reporting, there were more events reported in the fixed-dose combination group than in usual care, but the overall numbers were small, and this was not significant. This table shows the serious adverse events, and in summary, there were no surprises. A similar number of individuals reported having one serious adverse event. You see in line 2 there. And overall, there were no differences between the two groups in this context. So in conclusion, a fixed-dose combination strategy, including aspirin, statin, and 2 blood pressure-lowering drugs, improves adherence, blood pressure, and cholesterol in patients with established cardiovascular disease and in those at high risk. And this effect, a 33% increase in adherence over a median interval of 15 months, was evident in a trial population with an unusually high reported use of indicated medications at the outset. Thanks for your interest.
Thank you very much, Dr. Thom. So Drs. Sidney Smith and Andrew Tonkin will be the discussants for the multivitamin and UMPIRE studies. They have a conflict at the moment, but they may be available when we get into the post-briefing individual question period. So at this point, we can open up the floor.